Hello, class. Welcome to Chapter 8 in our Week 4. I'm going to provide a supplementary lecture for the reading and the course materials. So I hope you enjoy this lecture, and I hope also that you don't replace this as a reading, but it's something that you supplement the reading with. So we'll start the lecture. So this is about the kaleidoscope of advanced of collaborative care and advanced practice. This is a topic that is very near and dear to me because you cannot give patient care alone. It really requires a team approach, but it also requires respectful and mutual respect and collaboration for each person's expertise. This chapter has never been more important, I think, in your future role as an APRN. So the history of the changing relationships, the chapter starts off by discussing the background of Florence Nightingale described the role of nursing as a set of relationships to medicine and hospital administration set within the social structures of the time. The nurse held a subservient role. The physician had subservient role to the physician, and this continued to define society's general sense of the nurse role even today. In the 20th century, the role evolved to the RN-MD relationship to occur more within the hospital setting, and then kind of became this triad of MD, RN, hospital superintendent. Collaborations evolved during the Great Depression with organizational collaboration, but not quite at the individual level. Around the 1950s, the ANA began to spell out the role of the RN and establish a distinctive practice. And eventually this led to the model that is established today of valuing each profession's role within a separate but equal importance in the patient care. The growth and acceptance of the APRN role has hinged on the willingness of the profession to acknowledge and support the role, provide advanced education and experience, and promote clarity of the role that facilitates development of a sense of identity and clear understanding by other disciplines, policymakers, legislators, and the public. Each of the 4 APRN roles that are kind of lined out there have worked towards autonomy in practice. And it's really critical for the practice of all APRNs, while maintaining clinical practice distinctions, to be conceptually united, stressing commonalities while acknowledging differences in practice patterns, but promoting this interdisciplinary focus in their practice. So the framework for collaboration as laid out is kind of a dynamic, transforming process of creating a power-sharing partnership. This requires a shared decision-making model, relationship building, and flexible distribution on both status and authority. Key attributes of each of the components of collaborative practice include like an autonomous, for one, the separate and unique practice spheres. That means there's autonomous, trusting relationship and confidence in your partner's skill. Common goals mean like bi-directional referrals and consult. That doesn't mean that I just consult out and never hear about follow-up. So it's bi-directional. They follow up and they send that follow-up to you. Shared power control. This is also bi-directional referrals and consults, so shared power control over patient's care, a say in patient's care, so it's not just unidirectional, and the workflow is also shared as well. Shared power, mutual concerns. Um, this is a consensus-driven decision making. There's equitable reporting lines and evaluators. There's mutually defined goals of the practice. There's open and informal communications. And the informal is pretty key because you should not have to go through a formal communication process for clinical consult. There should be parity between providers, positive support by colleagues, and then also support staff and consumers should be part of this mutual concern framework. This will become, very clear depending on what type of organization that you work for. I have worked for an organization that really saw the APRNs in a different role compared to physicians. And these inequalities and inequities will become very clear when you become a part of that organization. And so, hopefully you strike lucky and you are part of an organization that really values and creates equality among physician and APRNs. But you will see some of these things come through, or lack of these things coming through, depending on where your first workplace is. So there's a continuum of how this collaboration works, and in the intensity of the professional relationships and collaborative structure kind of depends on these four ways of interacting around patient care. So unidisciplinary, that's your role. You're like, I am a nurse, or I am a social worker, I am a medical provider. We know what we went to school for, our individual contribution to the pie. So I'm going to kind of break this down into an actual patient example. So, for example, unidisciplinary role. I'm a nurse practitioner and a patient sees me for shoulder pain. I give them ibuprofen. Done. Okay? Then we move into the multidisciplinary continuum. So this is an information exchange within patient care, but there's not really shared planning. So example, I refer this patient with shoulder pain to physical therapy. I inform physical therapy that I'm sending them for shoulder pain. We're not collaborating on the care, but we're creating a multidisciplinary approach to helping this patient with their shoulder pain. Then you transcend into interdisciplinary on the continuum, and that is really when you are developing a relationship to meet a common goal. So, for example, this patient sees physical therapy for shoulder pain. Physical therapy relates their progress or lack of progress back to me, and maybe suggests further testing, like an MRI or an injection, something. Or we decide that they're going to alternate visits and they're going to be following up with me after PT, kind of this back and forth. Then, at the peak of the relationship status is transdisciplinary. And that's where there's this shared vision and it transcends any turf issues. A bad example of this would be if PT suggests an MRI and I say, don't tell me what to order. He doesn't need an MRI. Don't question my authority. A great example of this is great. Let's get an MRI because I respect your judgment in assessing shoulder pain. Let's see what other resources are available to him and what further testing he might need. So have them come back to make an appointment with me and let's get this started. And then you continue to collaborate on approaching that patient care. What barriers exist to this? It sounds so ideal to be in this transdisciplinary model, but we don't live in a perfect world and there are barriers that exist. So the texts explain this with an awesome visual called the iceberg effect. Icebergs are huge, and usually their size and greatness is mostly underwater. And so we don't really see the whole picture. It's a great similarity to professional life. What we see of the iceberg are the obvious problems. What's underneath are the not so obvious problems. So obvious includes policies, objectives, communication system, job description, like shared task. You know, you don't. There's no argument on the not so obvious. But then there's these invisible issues. That's the underwater portion of the iceberg. Sorry. And that includes like power networks, values, norms, informal communication, personal perspective, relationships, things that are a little harder to define. And so those are huge barriers to this collaboration and practice. So why can't we just get along and work together for patient care? Because of these 8 general barriers outlined by Joel. So educational isolation is one of those. And that's kind of what I touched on earlier in that unidisciplinary approach is we know what we know. We've been indoctrinated into the role that we have, and we don't quite see the whole picture sometimes because of lack of knowledge. So there's also professional elitism, which is a sense of importance and unique worth. So it's kind of a sense that we're better, or we're the first, or, and you'll see this if, maybe doctors get their own office, but nurse practitioners get a cubby. That is something that's a really obvious physical result of it, but it's kind of this essence of professional elitism. There's also the organizational hierarchy. So health services revolve around a professional authority with foundational structure or dominance by a single profession over a variety of other subordinate professions. And the idea of subordinate is that they are less than, which, historically this has been the administration and then the medical authority. But this continues with needing supervision over practice, and that's one way that this hierarchy is maintained. But it's also just the concept and belief and values that your role is the most important, when in reality you could give really great care as a physician, and then you order an x-ray, and you are powerless to give that x-ray if you have not been trained in how to provide that. And so the x-ray technician's role is just equally as important as the medical provider's role, because you can't get anywhere without them. Unrecognized diversity is respecting and acknowledge the diverse expertise that each member brings to the table. Scope of practice also, it's the extent of the clinical actions, decision-making, and patient management responsibilities authorized by state and federal law. So when you have really strict scope of practice regulations, that also kind of rolls into this professional elitism, which also is a barrier to collaboration. Role and language confusion is, for example, is the APRN supplementary, substitutive, or complementary to the medical provider role? So long as the APRN role does not have full practice authority in all states and must have MD supervision, this will remain confusing. So, our goal is always to be complementary and individual to that care, but with this practice authority or the supervision, so also the, sorry, I was getting a call there. Communication patterns, one way, communications, inadequate structures in place. This creates like a defensive, collaborative practice and non-collaborative practice environment. Also, professional dissonance. This is like, again, they kind of all mold into each other, but it's difficulty respecting each other's skills and roles, and this really inhibits collaboration. So these are just 8 that the author of this text came up with. Can you think of other barriers that may not be listed? So strategies for success of collaboration, collaborative practice is to create a collegial team, accept growth and development as a joint responsibility, use protocols and guidelines wisely. Also, watch your language and how you represent yourself in your profession. Do you call yourself a mid-level provider, an advanced practice clinician, or non-nurse? Lastly, we need to socialize students to learn the communication skills needed for collaborative interactions. So you have the opportunity to be a preceptor. This includes opportunity for them to consult with an MD, PT, X-ray, interact with many different professions other than the NP role as possible. So we need to start them young. So a little assessment question: describe which quality describes the goal for people who mistrust each other to begin working together with a common sense of purpose. So those are like mental models, personal mastery, systems thinking, shared vision. Answer is shared vision. This shared vision is described by Seng as the first step in allowing people who mistrusted each other to begin to work together as it creates a common identity and sense of purpose. A little learning check. So emerging models of collaborative practice include the following. So shared governance. This is a collaborative organizational model in which management and staff acknowledge that their interdependence and power is balanced equally on issues relating to nursing practice. ACOs, they are collaboration among primary care and specialist clinicians and hospitals and other healthcare professions, and they accept joint responsibility for both quality and cost of care provided to their patients. Medical homes, they're moving away from that traditional primary care model and seeks to provide coordinated care through the interprofessional team of healthcare providers, with the idea to reduce repeat hospitalizations and then promote effective and timely access to care. Shared decision making. So this means that the patient is actively participating in their treatment decisions. No longer is the provider providing direct care without consideration of what the patient can or is willing to do. I have an excellent example of this in my practice just this past week. I had a person who was diagnosed as prediabetes, and they came back. We did a repeat A1C, and it was through the roof, in my opinion, at that time. She's 70 years old. I talked to her about starting insulin, and she said, absolutely not. What will be is what will be. And so I'm not just out there prescribing insulin for her, knowing that she's not going to take it. So we decided that we're going to just start another pill, which I told her we're really not going to get good effects with this, but we're going to give it a try. And she was okay with that. And so if that's the best we can do, that's fine. And so making sure that patient is part of the decision-making practice or treatment is critical to this. Another concept of this is creating a patient navigator. So they're not necessarily clinically trained, but they're there to help people navigate the healthcare system. And this new role is emerging and is, with some hospitals that are really kind of cutting edge, and this is what we're going to see a lot more of. Another assessment question for you: which of the following describes a key barrier that challenges collaborative efforts? Organizational hierarchy, shared governance, shared decision-making, or accountable care in organizations. And these, as we talked about, organizational hierarchy, that's a key barrier that continues to challenge collaborative efforts, including educational isolationism, professional elitism, organizational hierarchy, unrecognized diversity, role and language confusion, inadequate communication patterns, and professional dissonance. So, 10 new roles to redesign and improve care. One is care based on continuous healing relationships. Patients should receive care whenever they need it and in many forms, not just face-to-face visit. This role implies that healthcare delivery system that should be responsive at all times, 24 hours a day, every day, and access to care should be provided over the internet, telephone, and other means in addition to face-to-face visits. That's when you start getting telemedicine involved. That's when you are going to see a lot more primary care clinical practices taking call. This is a big deal. Customization is based on the patient needs. The system of care should be designed to meet the most common types of needs, but have the capability to respond to individual patient choices and preferences. And this includes language barriers, cultural needs. It should be a redesigned system for that. The patient as the source of control. Patients should be given the necessary information and the opportunity to exercise the degree of control they choose over healthcare decisions that affect them. The health system should be able to accommodate differences in patient preferences and encourage shared decision making. Also, shared knowledge and information, shared knowledge and the free flow of information. Patients should have unfettered access to their own medical information and clinical knowledge. Clinicians and patients should communicate effectively and share information. So this is where you see those online portals where patients should have access to their labs. No longer should they just be getting a call saying your labs are normal or no news is good news. Evidence-based decision-making. Patients should receive care based on the best available scientific knowledge. Care should not vary illogically from clinician to clinician or place to place. So we really should be staying up to date on those guidelines, and we should not be this lone ranger out there that's offering non-evidence-based care. Safety as a system property. So patients should be safe from injury caused by the healthcare system. This is a huge IHI priority. The need for transparency. The healthcare system should make information available to patients and their families that allows them to make informed decisions when selecting a health plan, hospital, or clinical practice, or when choosing among alternatives. And this really is where the role for that patient navigator comes in. And that can help with transparency. This, I think, is one of the rules that our system needs most, is this need for transparency. Anticipation of needs. Number 8, the healthcare system should anticipate patient needs rather than simply reacting to events. Continuous decrease in waste. We should not waste resources or patient time. Again, this is another thing that is actively needed in our system. Cooperation among clinicians. The final but most important, clinicians and institutions, and what this whole chapter is about. We should be actively collaborating and communicating to ensure a proper exchange of information and coordination of care. So this concludes the Chapter 8 lecture. I hope that you continue to read in further detail in the actual text, but this is certainly something that you're going to be referring back to at many times when you enter into that role as an APRN. Thanks for tuning in.